duration, and sometimes it also causes sleep fragmentation. And people who have sleep fragmentation on their sleep study, and if they are symptomatic, then they should be treated same way as restless leg syndrome. Although current recommendation does not want, again I emphasize, current recommendation does not recommend treatment for everybody with periodic limb movement syndrome if you see them on the sleep studies. Now, let's talk about the most important sleep disorder, which is obstructive sleep apnea syndrome. I'm going to go over the pathophysiology of this important disorder. Then we'll talk something about epidemiology, and then we'll do some discussion about the clinical presentation, how this condition reflects. And then what is the implication of obstructive sleep apnea syndrome on sleepiness, cardiovascular issues, and metabolic issues. And at the end, we're going to conclude as a take-home message. So the pathogenesis of the sleep apnea is multifactorial. Definitely obesity play a very important role here. Genetic factor also play a role. There is no specific gene which has been identified so far which is related to sleep apnea syndrome, but we have seen that sleep apnea has a familial tendency, so it's run in the family. It also, all these things causes the small pharyngeal airways, which ultimately causes your airway closure, and then if this is happening during sleep, called sleep apnea. This is again a sketch of the upper airway, including your nasopharynx, vulopharynx, oropharynx, and hypopharynx. And these are different players which could play a role in terms of deciding how one's oral and posterior pharyngeal narrowing is going to be, because all of these may cause narrowing of the air passage, which ultimately could cause obstructive sleep apnea syndrome. There is a balance of pressure in the upper airways physiology. Some of these are favorable, and favorable here, and some of the was causing the collapse. If you have a small airway size, upper airway resistance high, negative aspiratic pressure causing problem. If you have extraluminal tissue pressure, large tonsils, adenoid can cause problem. Obesity causing increased fat deposition in the posterior pharynx and hypopharynx area. Greater collapsibility of the airway, and smaller mandible size, which is the sometimes people even who are not obese, but they have significant lower size mandibles, and they have recessed chin. That could play a role in terms of causing the narrowing of the air passage. Contrary to that, a larger airways favor patency during a sleep. Sleep disordered breathing or obstructive sleep apnea syndrome is basically a repetitive episodes of partial or complete upper airway obstruction during sleep. You could see here in a normal phenomena, you're breathing okay, going through your oral and pharyngeal airways area and going to the lung, and there is no obstruction, there is no problem. On the other hand, people with the sleep apnea, this is an issue here. The narrowing of the air passage causing collapsing of the airway, and then it is causing the obstruction. This is the prosopographic reading of the normal breathing. You have normal airflow, you have normal thoracic movement, and you have normal abdominal movement during your sleep related to your breathing. People with the obstructive sleep apnea syndrome, there is complete obstruction of the airflow, but at the same time, patient still having some abdominal and thoracic movement. So what does it mean is that one is trying to breathe, but because of the closure here, nothing is happening. And because of this effect, your oxygen saturation drops from its baseline to a very low level. And this could go on and on and on throughout the night. Sleep apnea could be because of complete obstruction, which is called apnea, or could be partial, which is hypopnea. And you can see here, there is a complete obstruction of the flow. Here, you still have the flow, but it is 30% below the baseline. And if you have desaturation about 4% or more from the baseline, with a 30% decrease in the flow of breathing during sleep, this is called hypopnea. Another term which is used is called upper airway resistance syndrome, in which you don't see decrease in the flow, neither there is any change in the oxygen, but with successive breathing, there is increase in the resistance in the upper airway, which can be monitored by esophageal balloon or by the compliance of the chest wall or the EMG lead from the intercostal muscles. And then it ultimately causes arousals and then the disturbance of the sleep. So all these things can be combined into obstructive sleep apnea syndrome. Now let's talk about epidemiology of the sleep apnea. There are different kind of studies done, including the prevalence studies, most commonly known from the Wisconsin sleep cohort study and Penn State study. And then there is a huge study going on in the United States about the sleep heart health study. And this is basically a cross-sectional and longitudinal data in pre-existing cardiovascular disease cohort study. And a lot of data is getting from there. We are learning a lot related to its impact on our health through this study. And I'll share some of the information from these studies. And then the Cleveland family study also included different other markers, including the racial division in the sleep apnea, genetical factors in urban population versus rural population, and so on and so forth. What the studies has shown is that if you do a random sleep study, the study shows that this is about 25% of the men, again 25% of men and about 9% of the women, on the basis of sleep study only, documented to have sleep apnea. On the other hand, if you have sleep study done, but you already have asked question, and if the patient is symptomatic with the disease process, then the number dropped down to about 4% of the men and 2% of the women. And this is the study done in Wisconsin State and Roy's. About 1,200 patients were enrolled, and it was published in 1993. This study was confirmed by another study published in the American Journal of Respiratory and Critical Care Medicine in 1997, and basically they found the similar kind of data. And afterwards, there are multiple other population studies done in 5 different continents, and we are getting the same kind of information related to the prevalence of this condition. So there's a huge difference between polysomnographic data only and patient who has sleep apnea on the basis of PSG, and if they are symptomatic or not. So what does it mean? There's a large difference. What is the implication? Maybe the large number of people with subclinical disease exist in our societies, and we are unable to identify them. Whatever the tool we have, it's not effective for that identification. The other is, are we asking the right kind of questions? The questionnaire which we use, or the symptom which we are focusing, are we missing something? And then, what is the effect of age on the symptoms versus objective disease? Now, let's talk about how this condition presents itself. The most common symptoms are, number one, loud snoring. About 40% men, about 20% women report habitual snoring, although some people may disagree that there is nothing called habitual snoring. If somebody is having loud snoring, they may have a disease process like sleep apnea. Snoring has implication in social life and marital life. About 70 to 90% of the patients diagnosed to have sleep apnea on the basis of PSG, they snore. And only about 6% of the people who are diagnosed sleep apnea do not snore. And this is a study from a long time back from Annals of Medicine in 1991. Another important symptom is nocturnal choking and gasping sensation. One wakes up at the middle of the night because of choking and gasping.